For our supine evaluation, what we're going to do is we're going to check leg length. So under the medial malleoluses, we compare our thumb heights. We come in and we compare tibial heights, and then rotation of the knee. We then come in, compress over the hip, check the ASIS, and come down to check the pubic heights. I come up to the diaphragm to test side bending or rotation of the diaphragm motion and check the anterior portion of the ribs. Remember, I've done this posteriorly with the patient seated. I'm then going to test side bending of the thorax. And then I come in and do a specific evaluation of the cervical muscles, come up to the head, test the OA, and then if I'm doing a cranial evaluation, from there I just go into a vault hold or a Becker hold. So if we're looking at this image here, remember we have the mastoid processes out here laterally and the occipitomastoid suture. The occiput comes up and comes back between in kind of a semi-triangle shape. So we've got the occiput here coming up around foramen magnum. The cerebral aqueduct is here in red. And then what we have here in yellow is the fourth ventricle. So when we are doing this technique, our awareness and our goal of compression is to put a vector into this space. So we're going to compress from the lateral angles of the occiput towards the fourth ventricle in order to slow and then still the CSF flow to reset the cycling that's going on. So what does this look like when we apply it to the patient? So we're going to put our hands in kind of this bird beak, this bird nest way where we're going to overlap our fingers and we're going to place our thumbs on top. So thumbs go down the neck. So we're going to have basically the inferior nuchal line here. We're going to have inion somewhere around the middle of the hands, and we're going to have the top of the occiput up by our thenar eminence. So we're going to put a vector from the thenar eminence up toward that fourth ventricle. When we get in the right spot, we are medial to the occipitomastoid suture. And when we apply that vector, it's coming up toward the fourth ventricle, which is posterior to the external auditory meatus and in the center of the head. So we put one vector from each side to balance this out. Remember, the dura attaches to the undersides of the bones and then involutes to separate out the lobes of the brain. So if we're looking at the parietal suture, because it looks very similar to the spread technique for our fourth step, what we're looking at is not the restriction that's immediately under our hands in the suture here. We're looking deep to that. So we're looking at the space in that venous sinus and how this area is draining. Our goal with this technique is to improve the drainage. So when we look at the ASIS, we get sartorius and the tensor fasciolatae attaching here. When we look at the AIIS, we get the rectus femoris coming off here. When we look at the posterior portion, we get multifidus coming up and across, and we also get gluteus maximus, which goes over this joint space. From the pubic tubercle, we get superiorly the rectus abdominis, the pectineus, and then inferiorly, we have the adductors coming down. So these are the big muscle groups we'll use in treatment of the anonymous. So when it comes to treatment of the pelvis, pubic treatment always comes first. Why is that? Because when we look at the pubes coming across, the pubes should meet and be level. When they are not, when we try to transfer weight across this, just like in the posterior portion of the spine, we get some transfer through the pubes. So we're getting weight coming down that's trying to transfer across this setup. And instead of being able to transfer smoothly over and down the femur, what ends up happening is that we get strut muscles that end up taking on weight. So mainly it's adductor here to transfer weight down into the leg because we don't have leveling of the pubic bone. Remember, when we look at the pelvis should be a nice circle, and then we get form and force closure of the sacrum sitting within. When the ring is broken, essentially, we don't get good transfer. So it's going to change the way that the rest of the pelvic bowl is set up, and it's going to change that weight transferability. So for our innominate rotation, we're going to use the muscle to pull the innominate toward the barrier. So if we have a posteriorly rotated innominate and we are trying to move this anteriorly, we're going to take advantage of the quad activation to pull this down. If we are trying to rotate posteriorly, what we will need to do is take advantage of the hamstrings and the gluteus to pull that posteriorly, right? We treat an anterior nominate, it's stuck in that anterior rotation. We want it to move posteriorly. We activate the posterior compartment of the thigh.